So for patients that are fit enough to tolerate intensive chemotherapy, kind of our long standard of care has been these intensive induction and consolidation regimens. And some of the newer adaptations to these have included the addition of venetoclax to some of these intensive chemotherapy backbones, such as FLAG or CLIA. So this would be like FLAG-Ida-Ven or CLIA-venetoclax. And in phase 2 trials, both of these different intensive chemotherapy plus venetoclax combinations have shown really, really high MRD negative CR rates, above 90% in these patients. However, with the addition of venetoclax comes the potential for additive toxicity. And so one of the things that these trials are also reporting is a significant amount of infections and other prolonged cytopenias. And so what we really wanted to investigate in this kind of retrospective study was, how do we balance this really, really high MRD negative CR rates with the possibility of toxicity? And so we retrospectively looked at patients that were treated with either FLAG-Ida-venetoclax or CLIA-venetoclax at our institution and looked, one, at kind of their count recovery, and then two, how their outcomes varied if they had received either one or less cycle of consolidation, or two or more cycles of consolidation. So a total of 2 cycles, including induction, or 3 cycles or induction. And so looking at the cytopenias firstly, so we found that patients who had received an intensive chemotherapy plus venetoclax backbone really had, after subsequent cycles of consolidation, had a prolonged time to platelet and neutrophil recovery. And this, compared to historical cohort of intensive chemotherapy treated patients alone, was significantly different. And so this is what really prompted us to want to look at outcomes in these patients. So then when we looked at patients who, let's say these patients went to transplant, patients who had received one or less cycles of consolidation compared to 2 or more prior to transplant had identical overall survival and relapse-free survival. And then even more encouragingly, patients who did not eventually go to transplant, for whatever reason, the patients who received one or less cycles of consolidation had equivalent overall survival and relapse-free survival to those who received 2 or more. It should be noted that a lot of the patients who did not go to transplant did proceed to some other type of therapy. So that could be a maintenance type of therapy at that point in time. And so really our conclusions that we drew from this study was that, outcomes for patients who have newly diagnosed AML, fit for intensive chemotherapy, were not really adversely affected by fewer cycles of intensive chemotherapy plus venetoclax consolidation. And given the potential cumulative toxicity, this data might support using fewer cycles of intensive chemotherapy plus venetoclax consolidation once they achieve that MRD negative remission, and then they could consider switching to an alternative consolidation therapy, such as transplant or a maintenance regimens. But prospective trials are really needed to validate these findings, but just something that we're really excited about and trying to optimize.